This is what we call as lead time bias. What is this lead time bias? You can compare three graphs. So in the figure A, we have diagnosis due to symptoms and the death due to cancer. And in figure B, we have diagnosis due to screening. That is, we are able to pick up the disease a little earlier. So this is the time we have. The screening time, from the time of screening to the time when the symptoms appear. So this time is called as lead time. So what are we looking at is by picking the patient in the earlier time, that is the lead time, the use of the lead time should lead to a prolonged life. That is, we have some methodology in place, some treatment in place that will improve the patient's survival so that the patient life is prolonged due to the screening. So we have to look at a test which will have a lead time leading to a prolonged life because of the screening. Next slide, please. So this is what we call as the lead time bias. Now we have the length bias. What is this length bias? It depends on the biological behavior of a cancer. For example, slow growing, less aggressive cancers are more likely to be detected by a screening test than fast growing cancers. So that is the reason why we will not have a screening test for a fast growing cancer. For example, a leukemia or a lymphoma, which most of the time are fast growing cancers, we will not have much of screening test. Whereas when we have slow growing tumors like a breast cancer or a cancer cervix, they are relatively slower growing compared to a leukemia, and this is where your cancer screening tests are going to be useful. So length bias depends on this biological behavior of this cancer. Next slide, please. Now, bias in screening will always be there. So why is this bias going to occur? This is because overdiagnosis can happen. In case of an extreme form of length bias, then what happens is there is no change in mortality rate because many will regress spontaneously in screen state. For example, you should remember that neuroblastoma, okay? Neuroblastoma is a pediatric malignancy where you can use the test of urinary VMA. So what is the disadvantage in using this is because many of the neuroblastomas in very early stage of pediatric age group may disappear. They may disappear spontaneously. In these situations, if you use this form of testing, your extreme form of length bias means that the mortality rate, there will not be any change. So this may not lead to a difference in the mortality, and you may think that urinary VMA is as a test itself may not be useful. But the fact remains it is a very useful tool. You have to keep in mind that length bias can be a problem. Next is what we call as stage shift. That is, by using a test, you're going to pick it up in an earlier stage than that would have occurred in the absence of screening. For example, by doing a mammogram, you may pick up lesions in a very small state, like less than a centimeter, non-palpable lesions, compared to a lesion which we will normally pick when they are palpable. So for a sufficient screening test to be efficacious, it has to be in terms of, we look at the mortality reduction as the most important thing. So because of this, both the lead time and the length bias become important. For screen detected prostate cancer undergoing surgery would not have actually developed the disease or metastasis. So this is the meaning of this statement. A reduction in mortality as demonstrated in a prospective randomized clinical trial is taken as the gold standard for demonstrating efficacy of a screening intervention. So it is not important just showing that there should be a reduction in mortality, not important just because it's a common disease, not important because the screening test is a very easy to do. It has to prove in a prospective randomized trial that it's efficient and reduces mortality. So this is the way we select a screening test for cancer. And selection bias will always be there, because why is this? Because it's a healthy volunteer. For example, a healthy volunteer will commonly come for a screening test. People who enroll in the trials are more health conscious, and this selection bias, how do we eliminate it? It is reduced by good randomization. By randomizing, you will be able to eliminate selection bias to a large extent. Then you have to use the keep in mind two terminologies. Any trial or any screening test you do should keep in mind that there can be a drop in and drop out. What is a drop in? It is a contamination. Some participants on the control arm get the intervention, whereas drop out is participants in the intervention arm drop out of the study. So this drop in or drop out both can reduce the statistical power of the study. So this is important whenever you look at bias in a study. Next slide, please. Now, what are the guidelines saying about cancer screening? About which disease cancer screening has been advocated, and with what benefit and what recommendation. So for this, the world over, the accepted guideline is from the US, what we call as the US Preventive Task Force. They recommend four types of grading, and the fifth one is the current evidence. Okay, so when they recommend a recommendation is there, it means there is a high certainty of substantial benefit. When the recommendation is B, it means high certainty of moderate net benefit. And the recommendation is C, a moderate certainty that the net benefit is small. And a D recommendation means that the moderate or high certainty that the service has no benefit and the harms outweigh the benefits. So if you have a US Preventive Task Force recommendation of category D, it means that the screening test is not going to be very useful. And the other recommendation is I, that is the current evidence is insufficient to assess both benefits and harms. That means we still don't have the answer to know whether this test is beneficial or not. So the other guidelines that are followed is the American Cancer Society and the Institute of Medicine. So these are the screening guideline criteria that are being used. Next slide, please. Okay, so we start with few examples on breast cancer and how this task force, US task force guidelines are there. So what is this screening recommendation for normal risk asymptomatic subjects say with regards to breast cancer? You can see here self-examination in women more than 20 years. You know that is a good option, right? But what does the evidence say? Category D. That means self-examination alone may not be a very good screening tool, right? So by the time the lady picks up a lump and comes, that may not result in a mortality reduction. So yes, self-examination is good. It will help you pick up the lumps, but it will not help in picking up a disease where you can reduce the mortality. So this is the important things that you will have to understand. So what is a recommendation? A mammogram. Okay, whenever we use a word mammogram, keep in mind that there are confusing terminologies that are always in place. Mammogram generally refers to a X-ray digital mammogram. Then the other mammogram, so-called mammogram, is the sonomammogram. What is the sonomammogram? It is nothing but a dedicated ultrasound for the breast. Okay, ultrasound of the breast does not come under a routine screening guideline. It is only a X-ray digital mammogram which comes. The ultrasound has an adjunct tool, that is, it can be added on, but it may not be a separate investigation that can be used as a screening. So what does the US task force recommend? In women over 40 years, screen annually for as long as the woman is in good health. That is the American Cancer Society recommendation. US Preventive Services Task Force says 40 to 49 is the decision of the individual, and the patient should be able to do it in the age group 40 to 49. In the women more than 50 to 74 years, you can do it biannually. That is, the recommendation is to do a mammogram once in 2 years. And when the women becomes more than 75 years, it is inconclusive. That is, there is no evidence to suggest that it is neither harmful nor harmless. So the benefit seems to be most in case of the women between 50 to 74 years, and slightly lesser benefit in women less than 40 years. What about the women who are less than 40, say about 30 to 40 years? Can we do a mammogram? All of you should keep in mind that mammogram is not a very efficient tool in women less than 40 years, because in a less than 40 years, the breast tissue is more glandular and does not contain much of fat tissue at all. So the mammogram is not very useful, because in a very glandular tissue, the mammogram will not be able to pick up lesions better. More than 40 years, where the glandular component comes down and the fat tissue component is more, mammogram is more useful. So what do we do to evaluate tool as an evaluation tool in women between 30 to 40 is you can do an ultrasound, but it may not be recommended as a screening tool. And what is the recommendation for doing an MR mammogram? Magnetic resonance imaging, that is an MR mammogram, is not done as a screening tool for everybody. We do it in women who have more than 20% lifetime risk of breast cancer. Okay, so this 20%, we have certain family history like BRCA positivity, breast cancer antigen positivity, hereditary cancers, okay, leaf Romney, all these sort of situations where we calculate the nomograms based on whether the woman has more than 25% lifetime, 20% lifetime risk of breast cancer. Then you can do it with a MRI and a mammography annually. So this is the understanding that you should have with regards to breast cancer screening.